involved with RSN for nearly 15 years. Support from someone who's been there makes all the difference.
Hey David, what are you listening to?
Kidney Talk, an online radio podcast that talks about kidney disease and the prevention of it.
Oh, cool. Where can I find that?
Oh, you can download it on iHeartRadio, Google Play, and Apple Podcasts.
Oh, nice. I'll definitely have to download that.
Shout out to Renal Support Network, the annual Renal Support Network essay contest. I won the Renal Support Network contest last year, the Warrior, and we are all warriors. So thank you. Keep on doing all that you do, and be happy and healthy and keep the hope. Thank you, Renal Support Network. Woohoo!
As a kidney transplant recipient, I find that having an actual publication like Kidney Talk is an invaluable resource for any kidney warrior at any stage.
RSN keeps me informed of kidney advocacy issues so my voice can be heard.
I'm really looking forward to the prom this year and meeting people who are just like me. Dressing up is super fun and all the activities are amazing. Can't wait to see you there.
Hi, I've been participating in the Renal Support Network 30-minute fitness Zoom classes. Not only have I lost 15 pounds, but I can also strike a yoga pose like this.
When I created Renal Support Network back in 1993, I had no idea the impact that I would have among my peers. An illness is too demanding when you don't have hope, and peer support, education, and knowledge are crucial to our survival. We have a great week planned with some incredible speakers, great information for you to share, learn, so we can survive and thrive with this illness. It's imperative. So stay tuned. We're going to have a great event, and a shout out to our corporate mission partners for making this happen.
Our next presenter is Dr. Kamil, who specializes in nephrology in Los Angeles and has over 47 years of experience in the field of medicine. She's involved in clinical research and teaching in pediatric nephrology, nephrotic syndrome, and patient advocacy. She serves on the faculty of David Geffen School of Medicine at UCLA. Yay, that's where Jenna got her transplant. Teaching medical students and residents. She is the Cedars-Sinai Principal Investigator in the NephCure Accelerating Cures Institute with clinical research in nephrotic symptom. Welcome, Dr. Kamil.
Thank you. I'm just trying to figure out how to share my screen. Here we go. Can everyone see that?
Yes.
Great. Okay. So basically, I would like to, I designed this presentation mostly for patients, but also for parents. And I realized as life has gone on that children are not the only people that have to learn how to manage their health. So some of the tips that I've come up with are based on experiences I've had working with my mother, who had a lot of chronic health issues, and trying to figure out ways to keep her safe by making her information more accessible, both to her and to anybody else she might run into. So this is my disclosure. I'm a board member of NephCure Kidney International, which is a foundation, just had its 15th or 20th anniversary, supporting patients with nephrotic syndrome diseases. And I'm a principal investigator at Cedars with these studies. The Kidney Research Network also was known as NephCure Kidney International Network. And that is a collaborative study among several centers. And then I'm a principal investigator on these various clinical trials, most of them in nephrotic syndrome. So what I'd like to focus on today is like successful steps to successful management of your health. And that is a lifelong journey. And it involves, no matter who you are, you need to kind of get a handle on all these things. So the first thing is to know your disease. Or maybe number one should be know yourself, but know your disease. Secondly, know yourself, and that's going to be really important for how you interact with your healthcare team, with your self-reflection on how things are going, and also your family and your friends and so on. And then be your best advocate. That's going to be, it's a trip we all journey on. And then fourth, look for the helpers. According to Mr. Rogers, you always find people who are helping. And we have to sometimes realize when we are able to manage this ourselves and when we need help, and who's the best person to help us in different situations. So in terms of knowing disease, know your disease, this is a process. And as time goes by, even your healthcare team's learning more about the diseases. I can tell you so many diseases have our whole focus has changed over the years that I've been in practice. And you can get this information from your doctors and your nurses, as Maria mentioned. Also from reading articles, watching videos. And it's important, I think, as Maria mentioned, to keep the family involved as well as the patient, because people leave the office and they say, what did they just say? So you want to basically be able to both be on the same page, or all be on the same page and understanding what's going on. You need to know what the name of your disease is. And you may have obviously more than one disease, such as obstructive uropathy and high blood pressure. And what could the complications be, so that when you, for example, when a patient starts a new medication for a disease, you might say, okay, this is medication A, and you would say to the doctor, well, what side effects could I expect? So those sort of back and forth, and really taking charge of understanding what your diseases are and what medications you're on, what could be the complications of the disease and the treatments. And you want to know what caused your disease if it's known. That sort of helps to understand the evolution. And another issue is knowing your problem list, and don't be freaked out by it. My mother used to get really upset when she would go to the doctor's office and they'd pull up her problem list, which was like, I don't know, 10, 20 problems. And she'd say, don't show me that. I don't want to know about that. But basically, it's important to know what your problems are and don't be freaked out about it. We'll go into that a little bit more in a minute. And also importantly, your disease does not define you, but it can mess you up if you don't take control. So let's talk about the problem list. So this really helps the emergency room staff help you quicker. And it's basically, the problem list is a list doctors and other healthcare providers use as an organizer for their managing each encounter with the patient. It can be used to flag issues that need to be addressed at each visit. And it also helps providers decide which problems they're responsible for and which problems are handled by others. So your nephrologist might know that you have cataracts, and might ask you have you followed up with the ophthalmologist? But just knowing all these problems are really helpful. If you have diabetes, your doctors are going to think like, oh, I need to not give this medicine that might raise the blood sugars. So having that problem list accessible and in your realm of understanding is really important. And as a patient, it's useful to have a copy of your problem list so you have a way to organize your medical follow-ups, such as you see the diabetic doctor every 6 months and the kidney doctor every 3 months. So you have those sort of things that are going to be popping up, because otherwise things are going to fall off, and someone might say, oh, what happened to your osteoporosis? And you go, oh my gosh, I haven't looked at that for a while. I have my problem list loaded into my medical ID on my phone, so I want to spend quite a bit of time talking about medical ID. So in a few minutes, the problem list, example of the problem list would be kidney transplant status, deceased donor, January 2009, immunocompromised state because of transplant medications, mild hypertension, recurrent UTIs, hypothyroidism, asthma. So if you show this list to somebody who's newly taking care of you or newly involved in your health care, that's going to help key them into things that they need to really think about when they're assessing you, especially if you're in an emergency room in a different state, or you're seeing a new doctor for the first time. So when my mother was 90, I went and bought her an iPhone. This is not an ad for the iPhone, because I found out that this medical ID is downloadable. I guess I don't have a pointer, but anyway, it's downloadable on the Android phone. So if you can see the third picture over, it says medical ID. So you can download medical ID onto the Android system. So basically, you go to the health app, and the next slide will explain how to do it, so we'll hold off on that. But you can put in your name, your birthday, your medical conditions. I put my problem list there, your allergies, your medications, blood group, weight, height. You can also put in that you're an organ donor, and you can put in emergency contacts. So it helps first responders access your medical information from the lock screen. So say you pass out, someone calls 911, along comes the EMS people, and they can pick up your phone, and from a lock screen, they can look at your medical ID. And also, they can call your emergency contacts, and if you have an emergency, you can actually call the EMS system. So the way you get into this is you open the health app. This is on the iPhone. You open the health app and tap the summary tab, and then your profile picture appears in the upper right-hand corner. And then you click on that, and then under medical details, you tap the medical ID. And then you tap edit in the upper right-hand corner. And then there's an option to make it available from the lock screen on your phone. So if you're a teenager and you pass your phone around and you don't want people to see this private health information, you can not allow that to be shown on the lock screen. However, that does disable the wonderful benefit of being able to share the ID with emergency responders and turn on share during emergency calls. So, it's a trade-off, but I keep mine on all the time. And you have to enter your information. It's not going to appear magically, so you have to add your date of birth, your allergies, your blood type, if you know it, and then tap done. We've used this in our clinic as kind of a transition tool. So when we started getting kids, it's surprising how many kids, about everybody has a phone, a mobile phone. So we would have them come into clinic. We'd tell them about the medical ID. We'd help them load in the information, particularly their diagnosis and their medications. And for those of you who are transplant patients or dialysis patients, you know how many medicines you're on. It's a lot. So we would load them all in. And then the next time the patient came to clinic, we'd say, what medicines are you on? And they would typically look to their mother, and you go like, no, pull out your phone. So they pull out their phone, and there are the medicines. You're like, okay, are you still on the same doses? And they'd be looking at that. And then say after clinic, it's a transplant patient, you find out that the tacrolimus level is too high, and you call them and you say, okay, drop your tacrolimus dose to 1 milligram twice a day and change it in your phone. So that way they have their own double check for that, and it's in their pocket all the time. So I've found it to be really wonderful, and I thank the person at the AT&T store who introduced me to this when I went to get the phone for my mom. This is a really useful video on the medical ID. I tried to figure out how to load it into my presentation, but I spent like an hour trying to do it on 2 or 3 different occasions. I couldn't figure it out. But anyway, so you can go to just Google how to use the medical ID on your phone, on your iPhone, and then hashtag spina bifida, this really cute girl, and she does a 2-minute wonderful summary of what I just said. So this medical ID helps in an emergency. If you turn on the button to share when locked, emergency personnel and others can access your medical ID if you're not able to communicate or if you're too freaked out to remember everything. So you can realize that if you're in a crisis situation, things leave your brain. You just don't remember everything. It's there, but you just can't access it. And for example, with my mom, I put all that information into her phone. I was visiting her in Florida. We drove off to fax something. She didn't have a fax machine. And then 5 minutes later, I get called that she's passed out. They called the EMS. I get back to the house. She's woken up again, but they're asking me like, what medicines is she on? They're going like, oh my God, she's on so many medicines. And I go, oh, wait a minute, it's in her medical ID. So I just opened her medical ID. There was all the information. And at that time, the EMS people had never heard of it. So it was really, really helpful to have that information right there. But again, you have to load it in yourself and make sure that the information is kept up to date. Remember to update your medication list whenever there's a change. And again, if someone presses the emergency SOS, it calls emergency services and also your emergency contacts with your location. So whoever you list as your emergency contact will know that you're having a crisis and where you physically are. I would like to point out too, the health systems have apps that also have several features, such as the medication list and who your doctors are. We have one at Cedars where I work. I'm sure UCLA does. I know my brother has one in Texas because he shares his labs with me sometimes. But again, these hospital app systems, to my knowledge, don't have the emergency SOS feature. So I think this was a real breakthrough, and I just have to applaud whoever developed this app because it's terrific. You can get it on the Android and it's built into the Mac. So then that brings us to knowing yourself. So this is basically a lifelong journey for all of us. And I think we should be doing a lot of self-reflection as time goes by, as a person as well as a patient. So like, what makes you happy and what makes you afraid, and when do you feel overwhelmed? Also, what behavior in others really irritates you? So you might not be able to fix that behavior in other people, but you can learn how to manage it in yourself and how you respond to it. And it's okay to take a breath when you need it. So I'm primarily talking about these sort of, how all these insights are going to help you interact with your healthcare team. So if you find someone you have to become your own best advocate. So if you find someone important in your health team is upsetting you, find a way to let them know that. Like, oh, you're using too many big words when you explain things. You're talking too fast, can you slow down? And, oh, doctor, as they're trying to run out the room, I do need to tell you more about my symptoms. I'm worried about such and such. So, speak up. And that's really important. But also remember, healthcare providers are human too, and maybe stressed out, especially, with their huge, very busy schedules. But again, the vast majority are trying to help and try to be diplomatic and not confrontational, and take the lead to educate your providers about your needs. And that may take several visits to accomplish, especially if you have a new doctor. You walk in with your, 20, 30-year history of kidney disease going back to infancy, and they don't know anything about, your bladder issues, and that you've got this, strange bladder urinary drainage system that they never heard of, or some of the things you're bringing to their attention are like new, and they have to read up about it, or they themselves are feeling overwhelmed. So just realize that a new provider, it may take a little while to get to know you, and give them a little bit of time, because it's not the sort of thing that that many people are able to jump into. It's really a wonderful advantage if you live in a program like Maria's, where there's a transition from one person in the system to another person in the system, and you've been handed over. But many of us don't have that luxury. So you need to be able to come intelligently to your new providers. And I've heard several adult doctors complain, like, oh, I got this new 22-year-old patient and his mother came with him. It's like, I say, aren't you lucky? Because the mom knows some histories that the 22-year-old may not. And some of our 22-year-olds may have developmental issues and executive function issues, so they actually need somebody in there with them helping to navigate the system. But if all said and done, if you can't communicate well with a healthcare provider, try to find someone else who understands and supports you better, because it's not every person is going to be a great fit. And I've had occasional doctors that I didn't go back to because I didn't feel like I was communicating well, or they were paying attention to my needs. So this is Dr. Rogers, who talks about look for the helpers. So it's important to be independent and take charge, but sometimes you need a team to back us up, even if we're an adult. So everyone needs to consider who's your best team. there are going to be certain characteristics for team members. One is someone who's available. So if someone is like the perfect person, but they live in Seattle or Tucson, or they're not near, that's not going to really help you too much. It's nice to keep them in the loop, but you need also someone on the ground. You want someone who's calm and watchful and diplomatic as well. So for an example, when you're in the hospital or in another healthcare or personal crisis, you're going to need someone to help. You may need someone to help you with those situations. And when you bring a support person to the healthcare team visits, bring them to the healthcare visits whenever your team member accompanies you. You need to introduce them. So sometimes I'll be in a room and there's this other person sitting there, and you don't know, like, is this their boyfriend or is this their cousin or what? So it's take charge, introduce this person to the healthcare team and tell them what their role is. There's a really good book called In the Country of Illness, and I put a picture of it in the bottom of the slide. And it basically talks about the importance of having somebody join you on your journey. It's going to, be in crisis. You want to be in charge. You want to understand everything, but it's also important to have somebody else there, checking the prescriptions that you brought home from the pharmacy that's for erectile dysfunction instead of immunosuppression. So those, because you're dealing with a complex situation, you want to make sure that you have a backup person. Also, who on your healthcare team can help and with what? So in hospitals, we have the luxury of having social workers. If you're dealing with a private doctor, they don't really have social workers, but you may find that the office nurse has become really skillful at doing some of these things that our social workers do. But our social workers can help with navigating the healthcare system and insurance coverage. Figure out what your insurance benefits are. For a young person, you can lose your parents' coverage at 26 currently. We have a program in California called California Children's Services that is a wonderful supplement, and you lose that at age 21. The social workers can help with transitioning to adult healthcare providers. They can help provide referrals to social services agencies, resources for educational and vocational programs. We have a program in California I'm sure it's nationwide, for vocational rehabilitation. So if you have certain diseases and you have certain disabilities, you qualify for vocational programs that will help train you for careers. Sometimes they're sort of misused. I just have to mention I have a partner who's internationally brilliant, and Lori would know him. And he had polio as a child and was referred to vocational rehabilitation, and they were referring him to be trained as a cobbler. So that was misguided. He's really like internationally famous and helped. His ideas have helped thousands of patients. So anyway, but vocational programs often help with even getting a computer, for example. Counseling services, they can help with counseling services. Medi-Cal, and we have in California, Medicaid elsewhere, who's qualified for that. Sometimes if you have a disability, you qualify for Social Security as well, and Medi-Cal. The Children's Health Insurance Program is in other states. We call it Medicaid here. Section 8 housing, food pantries, homeless shelters. So social services are really, our social workers have a wealth of knowledge, and they can really help out. So you sort of kind of need to help, and hopefully your team will help you. Like, oh, so-and-so will help with this, and so-and-so will help with that. Doctors can help you identify doctors that you can transfer to when you move or you become too old to continue with your pediatric team, which is usually at age 21, sometimes sooner, sometimes later. And then, as Maria eloquently discussed, the doctors and nurses can prepare you for your transfer by educating you on your disease, your medication, what you need to know to take good care of yourself. And then in the future, often the pediatric team can be available with information if you switch doctors down the road because of a move or a change of insurance. Sometimes we do get, you change insurance and you have to change your doctor, which is really unfortunate, especially if you have a good relationship with that physician. The other thing is your electronic health record can help with health information and that the health information is shared accurately. So in the Epic medical record system, Epic is the brand name, which is used at many, many hospitals in Los Angeles. It's in UCLA, Cedars-Sinai, Long Beach Memorial, Kaiser. They all share Epic. The county system is on the county system, and Children's Hospital of Los Angeles is on a different health system. But if you happen to be seeing a provider in Epic, there's a little button the doctor can press, or the provider can press, that says Care Everywhere. And that allows, you have to get permission obviously to share, but that allows the healthcare providers to share information about the patient. For example, I saw a transplant patient who had been sick over the weekend, went to the emergency room at UCLA, had an imaging done, and I needed to find out what the imaging showed. So normally I would have had to have them sign a release and then the forms, and you have to deal with the medical records departments, which are their own bureaucracy. But all I needed to do is press the Care Everywhere button, up pop the images from UCLA, and I could look at the images. So that it was critically important. So if you don't know if your doctor's on Epic or a similar sharing application, it's especially if you're moving out of state and you're not sure who you're going to be seeing, obtain key copies of documents such as discharge summaries, operative reports, and sometimes you can get a health summary from your current doctor. Usually if you have a doctor who has OCD, like I kind of do, it takes a long time to really create a good summary for them to pass on to you. So oftentimes as a shortcut, the doctors will, create a package of information. Hopefully it's, selected. Again, my mother came out here for a procedure and I asked for records, and I had literally a 2-foot high stack of papers. They just had printed everything in her health record and there was essentially nothing useful in it. So if you can get the key information and make sure that whoever's providing you with that is giving you the right stuff, that's going to make it easier for the next person to digest what's been going on in your life. Also, don't forget patient support groups like the Renal Support Network, Nepcure Kidney International for people with nephrotic syndrome, PKD Foundation for those with polycystic kidney disease, Alport Syndrome Foundation for patients with Alport syndrome. I've probably forgotten some others, National Kidney Foundation, National Alliance for Mental Illness. We all know that life is stressful and we have other co-conditions that are making our life more complicated. So NAMI is a wonderful source, and I've had several of my patients' families work with NAMI, and they're just really a wonderful support group. So I heartily endorse NAMI. American Association of Kidney Patients, among others, there are plenty out there, but try to get your peer group and work together. And it's as Lori mentioned, it's really wonderful to have another group of people who understand what you're going through, and you can support one another. These groups will offer patient education, opportunities to get involved, chances to meet up with others with your same health challenges. And it's so helpful to meet others who are walking in your shoes. And in summary, that in this world, it takes a village for all of us. Build your own village, invite others to join, and work on knowing yourself and how to be diplomatic in interfacing with the healthcare team. Thanks.
Wow, that was great. Thank you so much. I love the, first of all, I love that you referred to your mother too, because I think a lot of these tips really can help all patients, across the board, because especially like the phone thing. I'm going to put myself information in there and my husband and my kids. I think that's a great tip. And thank you so much for that. Did we have any questions? Let's see. Lori, I see Lori typed, what about COVID in school? Lori, where'd she go?
Yeah, I thought that might be an interesting thing to just bring up while we have medical professionals. Are they giving any tips?
Yeah, I can say that Maria can tell me what they're doing in North Carolina, but we got lots of questions, especially I'm on the NephCure board, so we're getting a lot of questions from parents with kids with nephrotic syndrome. We get a lot of questions for transplant patients. Should my kid be in school? This is at the beginning of the pandemic. Should they be in school when they're being exposed to other children and they're on all this immunosuppression? So at that point, we didn't know much. And fortunately, the school's closed, so it wasn't really our call either. So we do tell people to be cautious. We just definitely reinforce wearing masks, washing your hands, staying distant, and distant learning is, I think, safer at this point. But again, I realize that that's a real handicap for a lot of kids not to be in the classroom and with others. But, and it looks like from what I've read that the transplant patients, for example, are not particularly have worse outcomes when they get COVID, but we don't want to run the experiment. We want everyone to stay away from it. Yeah.
And isn't that because of some of the immunosuppressant medication actually protects us?
Yeah, it appears that some of the immunosuppressants are protective. It looks like statins might be protective. It looks like vitamin D might be protective. So yeah, there are definitely some other. We've been into this for like 9 months or more than that, 10 months. But we keep learning, and so in the vaccine, they always worry about, like, okay, if you give someone a vaccine who's on immunosuppression, will they get a good antibody response? So those are questions. Like right now, we're talking about vaccinating people. Like, well, are our transplant patients or other immunosuppressed patients really going to have a good antibody response, and will it be protective? So those questions we aren't going to know the answers to for quite a while.
Yeah. So in terms of COVID, we do have, you have to follow the state mandates, and every state is different. Our state has a governor who took a lot of heat for closing the schools early. And so even though it's a conservative state altogether, and it was a red state in the elections, we have a Democratic governor. So things are a little bit different, and there is drama because there is disagreement with the Congress, the state Congress, and the governor. But in our state, we have fewer deaths than in California and in New York. There's a national registry of COVID pediatric patients. I think they have about 500 and something individuals so far registered. And most of the mortality, the majority of the patients who have mortality have other health conditions, not necessarily transplant. For example, patients who are on a ventilator, or who also have obesity, like the adults, or minorities.
Wow. Good information. Thank you so much. Yeah, I worry about COVID, of course, like everyone else. And I am involved in a couple of Facebook support groups about transplants and dialysis. And that question has come up often, is if it's going to protect them. I know, like with the flu shot, the doctor says, get it anyway, because you are going to get some benefit from it, even on immunosuppressives. And so our whole family gets the flu shot as well as the patient. But, and I wonder if it'll be the same. I guess we won't know until people start getting the vaccine. I don't know if they've done any trials with actual transplant patients. I doubt it, because this is moving along so quickly.
Yeah, no transplant patients, just healthy volunteers across the country in different age groups, different risk groups, in terms of racial breakdown. So they're trying to blend and make sure that they, get enough Hispanics, enough African Americans, enough Caucasians in different age groups from, I'm not sure which. My daughter-in-law, my son live in Shreveport, and they were in the Pfizer trial. They are in the Pfizer trial. So 40-somethings.
Yeah. Here's one question that came up. My dad has chronic kidney disease, stage 4, and is on home peritoneal peritoneal dialysis, should he stay at home as much as possible and cannot be exposed to others as best he can?
I would say that's probably decent advice, but you know, he can also, I think family could still visit him provided people are following, you know, social distancing and wearing masks and washing their hands, and don't come in if you're sick. I know there's the big problem with asymptomatic cases, and hopefully we'll have a lot better testing available. I know in LA we can get tested pretty regularly, but again, you could say like, oh, I was exposed to somebody who was sneezing, and so I got tested, but you don't know for sure that you're negative until maybe you have a second negative test. So right now we don't have enough testing to, you know, with confidence say that, oh, you're negative, you can go in and see someone who's immunocompromised, for example.
I have a comment because they said they have stage 4 and on peritoneal dialysis. I believe you have to be in stage 5. Is that right?
Yes.
You have to be in stage 5 to be on dialysis. So not that I'm trying to push you up the stage rank there, but I have a question. When is the good time to get transplanted? Like what GFR, and can you explain a little bit about maybe how they can get listed in some of the point systems for pediatrics?
I think that's a really good question. And what we've tried to do is the children get priority points because they're children, which is, I think, as a pediatric nephrologist, I think that's only right. So the way we do it is if we see somebody who has a disease that we know is going to progress ultimately to need transplant, we watch them very carefully. And then as soon as their GFR gets bad enough, but they don't need dialysis yet, we will work them up for transplant and list them before their 18th birthday, and we'll put them on an inactive status because they don't need a transplant right now. But while they're on the list, they're accumulating wait time. So wait time is a key to getting transplanted. So we try to get these kids waitlisted well before they actually need it. They're not going to take a kidney away from somebody who needs it while they don't need it. But as soon as their GFR drops to a critical point, then we'll make them active on the list. And so sometimes we're able to do what's called a preemptive transplant. So we are able to transplant these children before they have to be on dialysis, which is, when preemptive transplants first came out, people wondered whether that was going to be a bad thing, that maybe you needed to taste dialysis. So literally, that's what people said. That was the way, taste dialysis.
Dr. Kamil, I remember when people said, oh yeah, let them taste dialysis if they, because adherence is an issue for people, teenagers who have a transplant. And any tips that you could suggest on, I guess, 2 questions, tips for adherence, and just maybe it re-emphasize how important it is to make sure they take their meds. And then secondly, about living donation in the family, and any thoughts on that?
Okay, I think I'll let Maria.
I'll go to you, Marie, Dr. Ferris, since you.
No, Maria's fine. So in terms of adherence, I don't know that anybody has a magic wand. It is a very difficult area of our services, not just in the pediatric age group, but also in the adults. And part of the problem is the definition of adherence. We don't necessarily have an agreed upon definition of who is adherent and who isn't. And what do I mean by that? If you're taking blood pressure medicines, and if you're a a hypertensive patient, high blood pressure patient, and you take your medicines 80% of the time, then you could be considered a person who is adherent. Well, if you have HIV or a kidney transplant patient, if you take your medicines 80% of the time, that's not a great idea. So the definition of adherence has not been agreed upon. And so it's hard to study something that has not been accurately defined. In terms of adherence, it varies by family. We know that adolescents and young adults who don't even have a chronic disease, kids who are in college, have been studied as to whether or not they take risks. because people think that adolescents cannot think long term, that they're living adolescence and they're in here and the now and they cannot think about the future. That's actually a misconception that investigators at Utica, Dr. Reyna, R-E-Y-N-A, has written about extensively. And she has studied folks that are college students. So these are people who have better cognition than others, who have no health problems. And they have been giving surveys about, you can get $30 in a week, or you can get $60 in 3 weeks. Which do you think they pick? And they pick the $30, but simply because they want to have it now, not because they don't understand that in a few more weeks they'll have double the money. Also, they take risks, and they actually like to play the odds. So it's not like they are ignorant about, oh, they are adolescents, they don't know what they're doing. They actually know what they're doing, and they just but they like to play the odds. So the issue of adherence, there are some tools that have been developed. Bethany Foster had a nice grant that used technology. It was in collaboration with U.S. Center. So Bethany Foster is in Canada, I think in Montreal, and in combination with Johns Hopkins, I believe. Forgive me about the U.S. Center. And they used cell phone technology, text messages to improve adherence. And the use of technology is an interesting topic. We think that it helps because it's a media that adolescents like, but it does not necessarily give a lot more advantage versus using older techniques. I think having parents and patients that are well educated about the disadvantages of not taking the medicines help, but a lot of the times it's not just education, it's just taking chances and being good citizens, loving themselves. I think that if we have them, and you had a slide about that, Lori Hartwell. You said you have to learn to love yourself before you ask someone else to love you. I think if the patients have less anxiety, have less depression, and that needs to be controlled with medications, and if they love themselves and love their body, then perhaps there's a better opportunity to learn about adherence. But I don't claim to know the answers. It's a difficult topic. In terms of living donation, I would like to address to the group that living donation has gone down over the last 10, 15 years or so, Elaine. We are not quite clear as to why. Pediatric patients enjoyed a high living donation rate compared to adults, and now it's come down. I don't remember the number, maybe in the 30% range, Elaine? And it used to be 50-something% living donations. Do you remember the numbers?
I don't know the exact number, but I think that one of the issues was that the kids getting these higher priority points, the families kind of play the odds like, okay, my child's 8, he's going to need at least 2 kidneys in his lifetime. And let's take the first one from the list and then save the second one that, they'll have to wait longer for.
Right.
Yeah. So I think some of the patients, use that rationale.
Yes, but it is important to know that living donation has come down, and it is concerning, and not just in the US, but across the world.
That's an interesting comment, because I do think we need to do better policies to support our living donors. That's my
Correct.
opinion.
I agree.
100%.
A lot of education needs to take place, because there are publications that talk about the living donors over a long time will lose 4 years of their life by being living donors. And then, of course, things always get written. I have donated a kidney, and I had 2 good pregnancies afterwards, no problems, no issues, and I'm completely healthy. It's a personal decision, but it is a scary decision if you don't have all the facts in your hand.
Yeah.
I want to say a little something about the preemptive transplant. When my daughter was diagnosed, her GFR wasn't low enough to be listed yet, but as she 15, 16, 17 years old, the kidney function got worse. And we kept hearing about preemptive transplant. Now, this was 2001, so a long time ago. But every time I brought it up at the hospital, they'd say, "Oh, she'll get a kidney from the list. Don't worry about that." It's like, really? Do we have to put her on dialysis first? Oh, yeah. And so she started dialysis, emergency dialysis, because her kidney function dropped in 3 days. Her creatinine went from 6 to 12 in over a weekend. So she started emergency dialysis, which was horrible for her. And then that was 2 weeks after her 18th birthday. So she no longer qualified for pediatric points. So the timing was terrible. And, of course we learned this afterwards. It's always like, oh, why didn't we know? But, as parents, you don't really know. You're just kind of, winging it and hoping that you get some good advice, which, the transplant team we left that hospital and went to another after that. So, yeah, it's frustrating when you just feel like, you're pushing against these things, but you really have to kind of insist to be heard. And I think that's important. And I really appreciate both of you, your perspectives and your, support for families.
The list, the rules for adults for being listed for preemptive transplant are stricter. So if you have to have a GFR, I believe below 20. I have the number wrong because I'm a pediatric neurologist.
That's right.
You have to be listed. You have to wait till your GFR is 20 to be listed for a preemptive transplant if you're over 18. But if you're under 18, basically there's a lot of discretion that's granted the pediatric nephrologist, so that we will often list kids, not with GFRs of 80, but when they get down to 30 or 40, we'll go ahead and especially we kind of look at the slope of things and how quickly are things getting worse. And we know often kidney function gets worse during the teen years because the kids, what we say, outgrow their renal reserve. So, but you can get listed for a preemptive transplant as an adult, and even if it saves you a couple of years on the wait list, it's a real advantage. So it's something people should bring up with their transplant team if it's not already brought up, and bring up with your nephrologist. So, because sometimes the nephrologist won't refer to the transplant team until it looks like transplant is imminent or dialysis is imminent. So, or even the dialysis team doesn't often refer until, a couple of years after a patient's been on dialysis. So it's a real important time for people to be aware and educated and take charge of those kind of decisions.
Yeah, I think my sister just had a preemptive transplant. My daughter has a defective bladder, which has caused her kidney failure, but my dad died of polycystic kidney disease, and my 3 siblings have it. So my one sister's on dialysis waiting for transplant, and my other sister got a preemptive transplant from her boyfriend, and she had a great hospital. They were really proactive. They got everything moved quickly through, and even in COVID, they postponed for a few months, but she was able to get a transplant in June. So it was amazing to see that happen. And I think there is a little bit of, well, maybe she didn't suffer enough because she's not grateful enough, but she went through a lot to get to that point. So she's still struggling a little bit, I think, emotionally, but, she had to have a aneurysm removed before she could get the kidney transplant. So all of that proactive work by her transplant team really made a difference.
Yeah.
I have a question. Is there a scale of suffering that I'm missing? I don't know, but I mean, like anybody to say, oh, go on dialysis just so you need to suffer a little bit more. I think I want to take them out to the shed.
Yeah, and you meet the score to say, okay, I've suffered enough. It's time. Yes, no, that's a very good comment.
I mean, it's such a weird term, to suffer more with an illness like we committed.
The punishment, right?
Like we committed a crime, and I think it does kind of fall along with, we already feel guilty a lot of times for I know sometimes I felt like a burden. I felt like, oh my, all these different emotions. And then to say, oh, well, to hear that, I would, you know, it would put me through the stages put me right back to the beginning of shock and denial. Did you really say that?
I think part of it came from patients being non-adherent. I'm not justifying, because I think it's a crazy
Right, right. No, it's the bane of our existence.
Yeah, is that you get, oh my gosh, there was one patient when I was at UCLA that just stopped her meds. She was on her third transplant. She just, I mean, they had done, the team had done all these things to support her, and she just stopped her meds and lost her kidney. And I was thinking, I was so angry with her, not that I was interacting with her in an angry way, and she wasn't even on my team, but I was so angry about it. I thought, what if I had to take care of a patient like this? I would just like move to another state because it was like so hard to think about, you know, somebody could have used that kidney, and, you know, this is what all the opportunities she lost. And every time you lose a kidney, you get more sensitized. It's harder to get a second kidney, you know. So, and we had another girl that had a fight with her boyfriend, and he broke up with her, so she stopped her meds, and then she thought better of it. So she'd had pulses of steroids before, so she, quote, pulsed herself with large doses of cyclosporin. You know, it's like, so you have these sort of things as a provider where you're going like, oh no, they don't get it. So I'm not justifying that you haven't suffered enough, but I think people are saying like, people need to know what the feeling was like. They need to know what a great gift this is, the transplant.
But even when they know it, if they're in a moment of grief or depression where their cognition is impaired, no matter how much you know, right? It's a very difficult area of research, and it's a very difficult area of intervention. No one, up to date, no one has the magic formula to change this. We have done some strives as to developing patient education material that is accessible to all. That was part of the problem, right? We're talking to patients like they are providers like us, and they are, the parents at home are mini intensivists, mini nurses when they're doing PD at home, right? With no medical training. And so we assume that because they're doing this, they understand it and they know this, and they really don't. The other thing that we need to, if you are a parent in the audience and your child was diagnosed a while ago, ask questions of the provider, because we believe you're an expert. We believe that if you've been in our system for 10 years, you know everything about your patient's disease, and that is absolutely wrong. That is incorrect. We have demonstrated that time after time. So don't be embarrassed, and ask your provider to again tell you about, tell me again the name of my child's diagnosis. Tell me what has been discovered in this condition, just like Dr. Kamil was saying. Tell me about what can I do to improve the outcome of my son or my daughter? What can we do as a family? So just ask the questions, because we have limited time in our visits. Bring your little flashcards, bring your questions to the appointments, have your child write a question and have them come and ask the providers. Make us earn our money.
I remember being really shocked and upset when I saw Maria present at a meeting about how who the kids go to ask information about their diseases, and they went to the parents, and then the parents didn't have a very good level of understanding. I thought, oh, we spend so much time explaining this stuff to the parents. But then I was thinking back, like, we may have, had this child in our clinic in our practice for 15 years, and we spent a lot of time the first few weeks going through, this is what's going on, this is what we're going to do, this is how we can handle this. And then the next visits, they come back and you say, how are you doing? Are you taking your meds? Any problems? Okay, so we don't do the education piece. So after listening to Maria's presentation, we started reinforcing, like, with kids would come in and say, like, what is your disease? Why are you here? So we would try to, build the continuing education to every visit rather than just at the diagnosis, because you can't absorb all that information when you first get sick.
Right. Thank you, Elaine. Appreciate that.
Yeah, that reminds me when I went through docent training at the Huntington Library, and we would take groups of children around and teenagers and talk about the artwork. And the strategy there is not to talk to them, but to ask them what they see, because that would engage them. And they would also come up with some incredible observations that then it opens a discussion for what the artist was doing and what the process was and everything else. But it was great to stand there and say, so what do you see? They're waiting for you to, give a 10-minute talk on this painting. And it was really great I like the idea of saying, so what is your disease? Or ask the child, they'd be like, Mom, what do I do now? But I think, it does, it makes them participants, and that's always a good thing.
There's a comment by Miss Julie. It says that she's you see it? Carol?
Oh yes, I do. I'm a caregiver for my dad, so for me it is like having a child go through kidney disease. That's true, but the roles are reversed in our situation. And I am the primary caregiver for my dad dealing with peritoneal dialysis. So I know that I don't know everything, and I'm learning this one step at a time. And I think, that's all of us. I mean, with our parents and with our children, it's an ongoing, thing. But going to the appointments, having someone go with you, I think is key, because even when I had to have some medical intervention myself, it was scary. I think I just closed my eyes, my ears, and just showed up. And luckily, my son and my husband went with me, and they were able to, between the two of them, come up with what the information was. So having someone come along, I went to a CMS, a continuing medical education, CME, I guess, presentation once. It was all doctors, and they were talking about how much time they were spending with each patient. And then they'd hand them all these papers, and the people would go home, and they would know the next time they talked to him anything that they'd already told them. And so I raised my hand, and I said, they should bring someone with them. And they all looked at me like, oh, because that was more inconvenient for them to have more people in the office and more, but actually in the long run, it does serve them, I think.
Yeah, I agree.
Correct.
Okay, so
before we move on, Carol, there was a question, but is there a high age limit for transplant? I'm not sure if they mean a donated kidney or getting a kidney, but if somebody wants to quickly address that before we move on, if they can.
I think that depends on the center. So in the adult world, there would be an upper limit. I'm not sure, it used to be like 65, now it's more like 75. But if you have a really healthy 78-year-old who's otherwise healthy, then that's, in our center, I don't know if we have even a number anymore, but they look at the entire patient. You want to make sure that they don't have a lot of complications that would make their risk of not doing well with transplant. You don't want to put them in that setting. So it's somewhat on a case-by-case basis. The other thing is in our region, there's a very long wait for kidneys, especially if you're O blood group, something like 8 or 10 years. So for the older folks, there's something called extended criteria donors. So that if there's someone who has an auto accident or something and they happen to be over a certain age, I believe it's 60 or 65, then those kidneys go into the extended criteria donor pool. So they're still functioning kidneys. They still, have to meet criteria for being, something that would help somebody. And studies have shown that if you take those extended criteria kidneys and put them into someone who's, say, 75, we know that person might not live that much longer on dialysis, but they'll live longer if they get a good kidney transplant. So studies have shown that there's a mortality benefit for getting transplanted. So you offer, when you put someone on the list who's older, you'll say, would you be willing to accept an extended criteria kidney? Those come up faster. So, this whole wait list thing is it's an art form. But so if again, as the kidneys get older, whenever the kidney comes up for offer, it's looked at to make sure that the donor has good function. Sometimes if the donor's older, there'll be a biopsy of the kidney to make sure it's in good shape, that it would be likely to work for an extended period of time in the recipient. So Yeah, I think that, I don't know if any centers have hard and fast rules about upper age. Probably a 90-year-old they wouldn't deal with, but the 70s is probably fine. I don't know about the 80s. It depends on the center probably, and the general health of the recipient.
That makes a lot of sense. Thank you. That's great information. So next we're going to move to, I don't think there's any more questions. No.
There's one question.
Where?
How do the doctors on the panel feel about patients recording the appointment in the appointment?
Yeah.
I think it's a very progressive thought. I think most of us would welcome that. Elaine, what do you think? I think that there are very few doctors who are suspicious about being sued, because that's part of the being suspicious. Why is this person recording? But I think that if you have a good patient-doctor relationship, your concerns for being sued decrease. I think you have to ask permission, though. In most states, you cannot record a conversation unless you ask permission. I think that there are a few states that you don't have to ask permission, but in most states, you have to ask permission to record a conversation of any kind. And as long as you say to the doctor, I'm recording this because I want to make sure I remember our conversation when I get home, everybody understands that.
Yeah, I think it's, again, I would underscore what Maria said, that it's important to, tell the doctor why you want to do it and at least ask their permission. I think I think it'll go over better. Some hospitals, I don't know if our hospitals changed their policy, but for a while there, they didn't allow it. Probably our medical legal people, risk management. But anyway, I think it is it's an excellent tool. Also, if you have one parent who came to the visit and the second parent didn't come, then even when my kids were little, I take them to the doctor, and my husband always asks the question, "Did you ask them blah?" And he said, "No." So anyway, at least all the information is there, and you don't have to try to reconstruct in your head what went on actually. So I think it's a useful tool, and I think probably many doctors would allow it. Just inform them, don't keep the recorder on in your pocket. That's probably not nice.
And there are a bunch of activated parents that the father would happen to come, and the mother knows most of the information, of course, as usual, and they would put the mother on FaceTime. Yeah. So people are pretty resourceful, and we welcome that.
That's great. Yeah, we record them because my husband's disabled, and so for him to be able to get some of his questions answered, because I come home, he says the same thing to me. Well, did you ask this? Did you ask that? I'm like, why don't you write these things down before I go? I can't keep all this in my head. So I think recording is great, and it's a great tool that we didn't have for years. So.
And a shout out to our corporate mission partners for making this happen.